This is a 37-year-old poorly controlled type 1 diabetic patient who presented to the retina clinic with floaters and severely decreased vision in her right eye following blunt trauma 6 days prior. She had a 25-year history of uncontrolled diabetes with her last A1C of 11.9% and non-compliance to her medical regimens. At the time of presentation, her vision was 2200 in the right eye and 20/25 in the left. On examination, she was found to have advanced active proliferative diabetic retinopathy in both eyes, with active vitreous hemorrhage and macula on tractional retinal detachment in the right eye involving the infranasal retina. She was scheduled for vitrectomy surgery and received anti-VEGF injection in the operative eye before surgery to decrease the chance of intraoperative bleeding. The fellow left eye also received anti-VEGF injections, followed by PRP later. To begin, the infusion cannula as well as 2-valve 25-gauge trocars and a 25-gauge chandelier were inserted and secured. Anterior vitrectomy is then performed, followed by core vitrectomy. Dense vitreous hemorrhage was observed overlying the posterior pole, and core vitrectomy was performed, exposing a large retinal break with surrounding subretinal fluid, thus indicating a combined tractional and rhegmatogenous macula on retinal detachment. Membranes were removed using the vitrector. Vitreous attachment surrounding a large 4-disc diameter break infranasal to the optic nerve is removed using the cutter. Additional tractional membranes and hemorrhages are carefully removed. Endodiathermy is now applied to the edges of the large retinal break to delineate the break as well as prevent hemorrhage while removing the retinal flap. 25-gauge curved scissors were then used to gently cut and remove membranes with special consideration towards not introducing an iatrogenic break. Preretinal hemorrhage is then removed using the extrusion cannula. Attention is then turned to the periphery where peripheral vitrectomy was performed 360 degrees with scleral depression. Air fluid exchange was then performed and subretinal fluid was removed using the extrusion cannula. After complete flattening of the retina, endophotocoagulation is applied around the area of the retinal break as well as 360 degrees. Additional subretinal fluid was removed from the optic nerve head. The case was now complete, the retina was flat and attached 360 degrees, and air 25% SF6 gas exchange was performed. This patient has continued to follow up with our service, and we are pleased with her post-operative outcome. This is a fundus photograph of the right eye 1 month after surgery where the patient has 20/40 vision, improved from 2200 prior to surgery. She was treated with PRP in the fellow eye and has been motivated since then working with her primary care physician to better control her diabetes.